Everyone. Tonight we've got a fantastic setup. One of the most exciting things that's occurring tonight is that we're doing something that does not involve COVID. And so we've got the privilege of having two renowned paediatricians, Anne O'Neill and Daniel Mason, who is going to give us a discussion on slow growth, iron deficiency and celiac disease in children. This has been done in conjunction with the Northwest Melbourne Primary Health Network, and we would obviously like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. A few housekeeping notes. Make sure your microphone is on mute. And ask questions via the question box, and if I get a chance and have a look at them, we'll try and put them towards the paediatricians on the night. We're going to have a little bit of a question time during their talks, but also devote a few minutes at the end of each talk for questions that might pop up. The session is being recorded as well. Now, my name is Scott Parsons, and I work at the Royal Children's Hospital in the GP clinic, and also I work for the Northwestern Melbourne PHN, and I've been involved in writing health pathways for GPs, and obviously predominantly in the paediatric department. And this is a great opportunity to let you know that we have just released a whole lot of infant pathways, and they include slow growth. And there's also a pathway on toddler nutrition, which includes a big section on iron deficiency. So the next slide, please. Just waiting for the next slide. There we go. So these are the new infant pathways. We've got adverse reactions in children, developmental dysplasia, eczema, infant rashes and birthmarks, and sleep concerns, jaundice, low birth weight and premature infants, the perinatal mental health, which is a complicated pathway, also some advice on plagiocephaly, and then there's a slow weight gain in infants, an unsettled infant. But probably the main pathway to let you know about, which is the hub of these pathways, when all the other ones are basically the spokes, is the infant routine check. And so this is the infant check at 6 weeks. Next slide, please. And the infant routine check is basically a way in which you can examine an infant at 6 weeks, or any age under the age of 12 months, from head to toe, which provides you with some guidelines on what you might see and what's important and what's not important. Next slide. So there's a snapshot of the infant routine check. You can print that off, and each little heading you find on the left and right side, in the actual pathway, there'll be a drop-down box which will give you more information. And I'll show an example of that, and a little snippet of what you'll learn for next part. So there's the drop-down boxes. Now let's pretend we've got an infant who's got a little umbilical granuloma. So if you click on the abdominal exam, so next slide. There's the abdominal exam, and if you look at the umbilicus section after assessment, you'll see umbilical granuloma. Now let's have a look at the management of that's currently recommended. And down in the management section, you can see umbilical granulomas can be treated with table salt applied twice per day to the granuloma for 10 to 30 minutes and held in place by gauze dressing. And then there's a handout that you can provide to the parents. So that's basically certainly a new treatment for umbilical granulomas, where you don't have to worry about trying to do silver nitrate. Topical steroids is also an option if it doesn't respond to that. So that's the kind of thing that's in the infant examination. It gives you an example of what you can find there. So the next slide. Now there's the little spill. So let's start with one of the topics tonight is iron deficiency in infants and toddlers, and this is the most common deficiency we currently see, and it's basically a silent problem whereby there's symptoms of virtually zero when you just have iron deficiency, but will become quite severe but subtle when you have iron deficiency anemia. And this is all covered in this pathway, the infant and toddler nutrition and feeding concerns. Next slide. So there's three things that I think are important in iron deficiency. Firstly, you're not going to find any symptoms and signs in most cases. You have to go hunting. So think about the risk factors, particularly the vegan parent who may have an Indian background, and they may have been exclusively breastfeeding, and then they've moved to cow's milk, and there may be an excessive cow's milk ingestion. That infant is primed to have iron deficiency. Symptoms and signs of anemia really will only start to appear when the hemoglobin is less than 70 to 80, not much before then. And the symptoms and signs are going to be quite subtle. The toddler will basically become lethargic and will be tachycardic, mild tachypnea, but really will only really have obvious signs when they're quite significantly anemic. The best way of seeing pallor with our mixed race that we have is the conjunctiva. The other tip that I find is that when I'm discussing cow's milk with parents, is I always use a body weight analogy. So for example, a 10-kilogram baby, if they're having 3 bottles of milk a day, that's 250 mils of milk, that's 750 mils of milk a day. And that's, with a 10-kilogram baby, that's 7.5% of body weight. So what I tend to find is that I compare that with my body weight. So 7.5% of my body weight, I'm 80 kilos, would be around 8 to 9 litres of milk per day. And that helps understand parents that it's far too much for some of these toddlers to be drinking. Next slide. That's this is in the pathway. So that shows you what a healthy conjunctiva looks like, and then what a pale conjunctiva looks like. And this is one of the most, this is probably the best sign for looking for pallor in a toddler. Next slide. We also have a pathway on slow weight gain in infants, and so that will cover many of the points that Daniel is going to be covering are in this pathway. Next slide. One of the most important aspects of that is understanding that a lot of infants will cross percentiles and they're otherwise returning to where they should be, or crossing percentiles is often normal in infants. And here's a couple of examples of a twins, one who's clearly had more nutrition than the other one. And so the one on the right-hand side is going to move percentiles to down and cross down percentiles. And then the one on the left-hand side, who's quite smaller, is going to probably move up. So you have catch-up growth and you have catch-down growth. And this is a normal variant you'll often see. Next slide. In the growth pathway, we divide infants into 3 types: healthy, thriving, moving roughly along the percentile charts; healthy, thriving, but changing percentiles. And those infants their height and weight will be moving in a similar direction. And then we have the infants to be concerned about. They'll be symptomatic, and their height and weight will be moving in different directions, or they'll be flatlining. So next slide. So if you haven't come across health pathways, please start using it, because there are some great pathways there across all ages. And obviously email for info@healthpathwaysmelbourne.org.au, and you'll get access to the username and password. Next slide. So Dan is a paediatrician working at Werribee, and he's got an interest in general paediatrics, neonatal medicine and refugee health. And we've also got Anne along tonight, who's also started to work at Werribee but has also been working on the peninsula for the last sort of extensive period. Next slide. I think we're going to be handing over to Dan to take over. If you can.
Thanks, Scott. So I'll just share my screen. I think the host needs to allow me to share my screen.
It might have been just a second before me, so I've just fixed it now, and hopefully.
Oh yeah, Grace. Yeah, that looks right. Can everybody see that? Is that?
Yeah.
Perfect. Okay. Thanks for that introduction, Scott. You've covered most of my talk already, so I'll have to beef it up a little bit. It's great to be here. My name's Dan. I'm one of the paediatricians, as Scott said, from Werribee. I also work at the Refugee Health Centre, Utopia Refugee Health Centre in Hoppers Crossing. And I'm here to talk about slow weight gain. And I think, I know we said we wouldn't reference COVID, but one of the good things about COVID is we're much better at doing this kind of education where we can all be at home and still kind of learning remotely. So what I want to talk about today is, as has been touched on earlier, some of the normal growth patterns and a definition of poor growth. And we tend to use that rather than the definition of failure to thrive. And we'll talk a bit about that later. Talk about some red flags for the pathological causes of poor growth. Talk about some of the initial investigations and referral pathways for this really common presentation. And we'll go through a quick case study and then make a few key points, and happy to answer any questions. So when I've got up here a slide about normal growth patterns, and as was alluded to earlier, it's really, there's a great variability in what's normal and what's abnormal, and it's a spectrum. So down the bottom is a rough guide as to how many grams per week infants should be gaining. However, a more accurate depiction is probably looking at the grams per kilo, and all infants will gain differently. What's important is that in the first 3 months, you can see the grading of that weight graph is at its highest. And as kids get older and get a bit more active, that gradient really flattens out. Important to remember that nutrition is really the main in children 2 years of age. And it's important to ensure that when we're plotting the growth, that we're using the appropriate charts. So we recommend using the WHO charts under 2 years and the CDC charts over 2 years. And then we also have some condition-specific charts, for example, for children with trisomy 21 and Turner syndrome, for example, for whom their genetic potential is a lot lower. We have specific growth charts for them. Another thing, I guess a general question is just to say, a general comment to try and ensure that growth charts are filled. And this, I actually gave a similar talk to maternal child health nurses. And so I think from a paediatrician's point of view, the first thing that we always do when we see a child who's had slow growth is to look at the growth chart to really track where the growth has been faltering, or if it's been faltering, and to try and get an understanding of the clinical history of that. I mentioned that before, that the maximum weight gains are in the first few months of life. And another important point to make is that correcting for prematurity. So we would define prematurity under 37 weeks of age, and we would correct the growth charts for these children until about 18 to 24 months. And interestingly, there's no great consensus as to when we should stop correcting, but probably around 24 months, I think, is generally accepted. And as Scott had mentioned earlier, important to remember that there are lots of healthy infants will cross and track along lower centiles than their birth weight in the first few months of life. And they're really probably moving from a point where the placenta is their only source of nutrition, with lots of things that can affect placental function, to being out in the world where really it's their genetic potential as well as their nutritional intake in those first few months. And the last point is that infants and children who are under the 3rd percentile with typical development without any of those red flags for pathological causes may well be within the normal limits of growth. And obviously there needs to be infants and people filling less than the 3rd percentile in a normal distribution, and often these are children for whom that growth trajectory is normal for them. But obviously with those children, we need to think a bit harder to make sure we're not missing anything. So what is slow growth? And we no longer call this failure to thrive. And again, some of that's reflected in some of the clinical practice guidelines. I think there are some additional connotations saying failure to thrive. So we prefer to call it slow growth. It's a really common presentation to both primary healthcare, as you will all know, as well as to paediatricians. And I would add to this that it's a presentation that's associated with significant parental anxiety. And it's a presentation that often involves quite a lot of transference of that anxiety onto the clinician. And so I think it's really important to acknowledge and remember that when we're trying to work out how extensively to investigate some of these kids. There are lots of variations in the definition. The definition that we generally use is a child or an infant with a current weight or a rate of weight gain that's significantly below that expected for age and sex, or if the weight's dropped greater than or equal to 2 major percentile lines. So, you know, I think what that means practically is if a child is dropping percentile lines unexpectedly, then I think it's worth ensuring or taking a closer look at the growth trajectory. Important to remember that you can't make an assessment based on a single growth parameter or reading. As we've mentioned, the trajectory is really by far and away the most important thing. You know, you might get one growth reading on a child who's on the 3rd percentile, who has actually been on the 3rd percentile since birth, and it's proportional to their length and their head circumference. And, you know, that's not a child who's necessarily failing or having slow growth. The last point to make is it can impact their development. And this is what we see when the slow growth becomes extreme and persistent. And so it certainly can affect an infant's ability to thrive. And I'll talk, you know, a little bit later about how we like to assess the child's development whenever we're assessing their weight. But it's important to remember that you know, slow weight gain and other medical issues can affect the development acutely. So doing a formal developmental assessment may well be impacted by the weight changes that the child has had. And I think I touched on this, it will impact parents. So we certainly see a lot of, it causes a lot of stress and anxiety, particularly in the kind of neonatal or early infantile age range, which is when we probably see most of our presentations. And it can certainly have impacts on parental mental health and parental behaviours around food and feeding that can often be quite detrimental and perpetuate some of the growth issues. So just a quick note about true nutritional insufficiency and the way that it presents. So you'll see there that the bottom percentile chart is the weight and the top percentile chart is the height. So when we have nutritional insufficiency, and apologies if this is pretty basic, first of all, we see the weight flatlining. So we lose weight first, and we call that wasting. And you can see that in this chart from 2 to 6 months, the weight has been static. The second thing we see is stunting. So if this is persistent, the body then decides that I don't have enough nutrition to grow, and we see stunting of the height. So you can see here that between 2 and 6 months, 2 and 4 months, the height is still going along the percentile line, and then it really flattens out from 4 to 6 months. And then the third thing we see, which is a really late sign, unfortunately, in our clientele, we don't see this very commonly, is that the head circumference will stop growing as well. And so that's a late sign, really, where there is not enough nutrition for the brain to grow adequately. And these are the children we really, really worry about. There are some other patterns that I just wanted to mention, patterns of growth that aren't the focus of this talk, but are worth mentioning. So I'm more focused on the weight and slow growth from a weight point of view, but if you see a child who's short, so a low height with proportional weight, we should be trying to think, is this a long-standing nutritional issue? So can you look back at the chart and see that there's been wasting and then stunting secondary to that? Or is this a genetic condition? So is this a syndrome where you're actually getting proportional growth that's smaller than what you would expect for someone who is non-syndromal, or is there an endocrine cause? So a classic presentation of this is hypothyroidism, where you get children who are quite short, but have a proportional or a relatively high weight. The other presentation from a growth point of view is with a small head, what we'd call microcephaly. And it's important to remember that, to think about microcephaly as a clinical sign rather than a diagnosis. So if you see a child with a small head who has a proportional or greater weight and height, you need to really think a bit harder about whether there are perinatal factors involved. So things like perinatal infections or teratogens, syndromes, or other causes of microcephaly. So I put these two patterns in to illustrate they're quite different from our more regular slow weight gain type presentation. So in terms of the slow weight gain, I guess some red flags for pathological causes of slow weight gain that have been touched on a little bit. Things that make me worried are rapid weight loss. So, often we'll get presentations of children whose weight is going up, but a bit more slowly than it should. But when we see children who either have static weight for a prolonged period or rapid weight loss, we get quite concerned that there's something acutely or subacutely has been occurring to cause this. If I see prolonged weight loss with evidence of stunting, I get concerned, because I think, physiologically there's significance there that the weight loss has been prolonged and significant enough to affect this child's height. If we have weight loss or static weight gain despite lots of interventions, so I guess the classic here would be a baby, so a young infant under 6 months of age for whom we think it's probably an intake issue, who's getting lots of top-up feeds, working on mum's supply, but despite that, the weight is still going down or static, then you need to think, is there something else going on here that I'm missing? And I touched on this earlier, but any weight loss with associated developmental delay or plateauing of some of the developmental milestones, and particularly regression, makes us really concerned about pathological causes. Development, I would hope, is an important part of your assessment in these children. And then I think the other one that's quite common, and I think Scott kind of broke it down in your guideline, weight loss with associated medical symptoms. So a symptomatic child with weight loss obviously is quite concerning as well. So common things would be cardiovascular symptoms, respiratory symptoms such as tachypnea. You might see tachypnea and worker breathing with feeds, gastrointestinal symptoms such as diarrhea and vomiting, or neurological symptoms would make me concerned too. So when I think about the approach to what's causing slow growth, we've identified that a child has slow growth. I try to keep it fairly simple. So I think about three things. One is what's going in. The second one is what's being utilized. So is the nutrition that's getting into the body being utilized appropriately? And then the third thing I think about is the body requiring more energy than what it should be? And so for the first one, what's going in, we think about the intake. So in the early neonatal and infantile period, often it's feeding issues. So does mum have adequate milk supply? Is the baby feeding enough? Is the latch okay? The second one is structural. So thinking about, is there something like a cleft palate or some laryngomalacia, an airway issue that's really adversely affecting this child's ability to feed? And then there are other things like delaying solids. So sometimes culturally we will see children, who are, 12 months and still exclusively breastfed and haven't started solids, or children who have developed an oral aversion for various reasons that can really affect their intake of adequate nutrition. Sorry, I'm just having a quick look at the... maybe I'll come back to some of the questions at the end. The second thing is insufficient utilization. So you're getting enough into the gut, but thinking about, is the body able to actually utilize the nutrition that's being presented to it? And so the way I think about this is there reduced absorption through the gut? So is there something going on the gut wall, or is there increased output? So, a classic one would be the child, the young infant who presents with vomiting, who's very, very hungry, has projectile vomiting really well, but can't seem to satisfy themselves and just vomit up after every meal. And you'd be thinking about things like pyloric stenosis or other kind of bowel obstructions. Diarrhea or chronic diarrhea, so children who have increased output, who just don't have the ability to absorb the nutrition that's getting into their gut. Malabsorption, and I think about in young infants things like cow's milk protein intolerance, celiac disease if they're taking solids with enough gluten, and then things more rarer things like pancreatic insufficiency and cystic fibrosis, or inherited metabolic conditions which can affect the body's ability to actually metabolize the nutrition that's being provided. The third main area I think about is increased requirements. So this is the hypermetabolic baby who has something going alongside, who needs more energy than what a normal baby does, and isn't able to get sufficient energy because they're really hypermetabolic. And really this is any chronic medical illness. So things like a chronic UTI can certainly do this, and some babies can present with a kind of chronic, slowly grumbling UTI. Any child with cardiac disease, and as I'm sure you will all know from your experience, there can be lots of kids who have maybe a very small VSD at birth, who as they get a little bit older and their pulmonary pressures drop, it becomes much more obvious symptomatically and won't actually present clinically until 2 or 3 months of age. And so they're the kids who are really huffing and puffing with every breastfeed, sweaty on the breast, who are not gaining weight despite feeding really, really frequently. Other respiratory conditions, diabetes I've got in there as an increased requirement, but it also obviously is associated with inability to utilize some of the nutrition as well, and things like hyperthyroidism. So I think that's a simple way to think about some of the causes of slow growth. The other thing to consider always is the psychosocial situation. So rarely is there not a psychosocial overlay to this presentation, whether it's parental anxiety, a lack of parental support. Sometimes there can be food security issues, issues with health literacy, and parental mental health. There can be cultural factors. There can be behavioral issues, and sometimes there are just mealtime traditions and conduct within a family that is not conducive to appropriate eating patterns and nutrition for young children. One thing that I'm not talking about too much in this talk, but I think it was brought up on your guideline, is always considering whether there's any evidence of abuse or neglect. And certainly a child who's unkempt and failing to thrive, I've got to stop saying that, unkempt with slow growth, who's nutritionally deplete, you need to always consider whether there's an evidence of neglect or abuse. So always try to, I guess, broaden out your differentials and examine the child to make sure there's no other unexpected bruising or evidence of injuries or anything like that. Commonly, we don't find one medical cause, and often the presentation is really multifactorial in etiology. So it might be some of the behaviours, might be a combination of the behaviours around mealtime, what kind of foods are being presented, plus or minus other conditions that might be presenting. Things like mild iron deficiency can have a real impact on a child's appetite and behaviour around food. So, sometimes even just replacing iron in a child with mild iron deficiency can help with their oral intake and their growth quite significantly as well. So in terms of the initial investigations and referrals, what I would say is there's a baseline group of investigations that I would do in most of these children. From a blood point of view, we would always look at a full blood count, ferritin to assess for iron levels, keeping in mind that in the setting of an intercurrent illness, you can often get a falsely raised ferritin, so you might miss iron deficiency if the child's got evidence of inflammation. I would check a UEC, I would check a thyroid to make sure we're not missing hypothyroidism, and I'd check the LFTs and glucose. We'll pick up most of the hypothyroidism in young babies on the newborn screening test, but it's still worth checking because obviously that's just at one point in time. I would check celiac serology and total IgA levels if the child's on solids or they're having feeds that contain gluten. And look for any evidence of micronutrient issues. And I've got active B12 there as the most important one because from a pediatric point of view, B12 deficiency causes irreversible neurological and developmental issues and damage. And it's something we can treat really, really easily. So if you're seeing a child who's got slow growth and any neurological symptoms or developmental delay, doing a B12 is really essential. It's one of the few things that we can treat really well. Always check the urine. As I said, sometimes you can have these slow grumbling urinary infections that can present with slow weight gain in infants. And I would usually check a stool for microscopy, culture and sensitivities, looking for infections. But you can also specifically ask them to have a look for fat globules and fatty acid crystals for evidence of pancreatic insufficiency. And sometimes if you're concerned about other malabsorption, you can check for fecal reducing substances, which are high with carbohydrate malabsorption and or a fecal pH. And often pediatricians will look for those things as well. And then I think the next kind of set of testing depends a little bit on the age of the child and the clinical presentation of the child. Often we would do an ESR in slightly older children if we were worried about a systemic condition, and a fecal calprotectin if you were considering something like inflammatory bowel disease in older children. There's a host of really complicated metabolic blood and urine testing that we would do in certain children if there was associated developmental delay or seizures or consanguinity or any other risk factors for metabolic disease. But I think that's something that is more to be done, through the pediatrician. But I think as a baseline, all children should, at some point in their investigative workup, get these things done. And the others just depending on the clinical presentation and symptoms. Who to refer to, and this is I think this is actually a bit of a tricky question. In my experience, often early on in life, if you've got a well baby who is not gaining weight as you would expect, but is very active, often the lactation consultant is really valuable if you think this is a feeding or an intake issue. And I know there are public lactation consultants available sometimes through the councils, and there are some private lactation consultants available. We also have lactation consultants at the hospital who follow up mainly in patients. Obviously, a paediatrician, we're very happy to see these kids, and we do have outpatient services available at Werribee Mercy. We're also really happy to be called through the hospital for advice. There's a paediatrician there 24 hours a day, a registrar overnight, a paediatrician during the day, to give clinical advice if you've got a child that you're worried about. And this extends beyond just slow growth, but we're very happy to be available. Pediatric dietitians can be very helpful in a child who might be a picky eater, or for a family who, for various reasons, are having difficulty providing appropriate foods. And then I've got maternal child health nurse and GP, because I know you guys are and so you're on the front line and often know these families the best, and the dynamics, and sometimes what interventions are going to be most helpful and effective for these families. So I just want to quickly go through a case study in the last 5 minutes or so. This is Mr. A. So Mr. A was a boy who was born at term, second child. There were no significant perinatal issues. He was born at 38 weeks, I think at about 3.4 kilos. And as you can see, in the first 6 weeks or so of life, he was exclusively breastfed, doing very well, and then got to about 6 weeks of life and had essentially static weight gain until about 10 weeks of life. At this point, his mum saw a lactation consultant and worked on breastfeeding. He was a bit of a fussy feeder, having short feeds, getting off the breast quite angry. So they worked with the lactation consultant, started expressing to try and increase supply, added in some top-up feeds, was on some medications through the GP, to increase supply. Despite this, over the next 4 weeks, the weight gain was static. And so Mr. A went from about the 50th percentile, or just under the 50th percentile, to less than the first percentile. His height and his head circumference continued to track along the 25th to 50th percentile during this period. At about 10 weeks, Mr. A got febrile, looked unwell, and presented to hospital, and ended up having a significant urinary infection with a congenital issue with the left kidney. So he had a vesico-ureteric junction obstruction. So was treated with antibiotics, given some fortified feeds, started on prophylactic antibiotics, and you can see his weight gain jumped all the way back up to the 50th within a month or two. So I used that case study. That was actually my son. So this was the son of a paediatrician and a GP who were trying to monitor this child's growth at home and missed a brewing UTI that was having an impact for quite some time. So I just use that as an example to say that it's really easy to miss quite significant pathology in kids. And so I think it's really important always to consider exactly what's going on. And if you've got a child who you're adding in interventions and the weight gain is not going up, you really need to think what else is going on. So in summary, I just wanted to reiterate a few of the main points. So children who are less than the 3rd percentile in their weight with typical neurodevelopment without any red flags may well and are most likely within the normal limits of growth for them. And I think that was reiterated by Scott earlier. Rarely is there not a psychosocial overlay to the presentation, and that may be causative or it may be secondary to the presentation, but usually good management of this situation requires an understanding of those factors as well. Assessment should include consideration of any of those red flags that we talked about for medical causes. So, static weight despite interventions to increase intake, rapid weight loss, any evidence of stunting, any evidence of associated medical symptoms, any developmental regression or plateauing. Often we don't identify any medical causes, I should say inverted commas, or we think the etiology is multifactorial. And please fill in the growth charts when you get an opportunity, because that's the first thing we do, both in hospital and in the outpatients when we're seeing children with slow growth. It's really helpful to be able to visualize exactly what's been happening. So I'm happy, I've just put up the resources here as well. So the Royal Children's has got a great resource for slow growth. And as you know, the Health Pathways, which I've only just looked at recently, has a really good resource. And I think this topic, it can be presented in lots of different ways. And so it's important to try and find a way conceptually that makes sense to yourselves. And it may be the Health Pathways, or it may be the slow growth Royal Children's Hospital pathway, but whatever works best. I think there's great resources out there. So
while you're looking at the questions, Daniel, I'm just going to make a couple of comments. Thank you for that. That was hopefully my health pathway reflected a lot of that that we wrote with the CPG in mind. The other comment, the Maternal Child Health Nurse app. I wondered if you could comment on that. I think that's quite a clever little tool that even GPs and parents should use. And the other thing is the fact that a lot of GPs may not have an infant measuring board, because an accurate height is very difficult without that. And I think that's really important if you're going to see a lot of kids that the GP obtains a proper measuring board for accurately assessing kids under the age of 2.
Yeah, so regarding the app, it's a great thing. I mean, interestingly, a lot of parents don't present that information to you when they present with their child. So I must admit, we're often, I think particularly in the area that we're working, we are often there, manually scribbling in the weights that we've got without having access to the app. But I think it's a great thing to have it online. And in terms of measuring, I think height is definitely the most difficult thing to measure accurately. And so when we are looking at the growth parameters, often there'll be 1 or 2 heights that are, off the charts that you need to accept might have been might have been aberrant heights, because it is really difficult to do. I'm just having a quick look. The other comment I would make is that, and I don't know if this has been your experience, but certainly with COVID, and I know I'm not meant to talk about COVID, but over the last 18 to 24 months, we've had a lot of families just from, you know, new migrant families who culturally would have their extended families and their parents and grandparents come over and spend a lot of time with them and help with the early period of feeding and growing. And we've had anecdotally, we've had a real increase, I think, in presentations of young parents who don't have their usual family supports around to help with this early period of life. And so I think the stress and anxiety about growth and development and feeding has been quite high in the community, because not everyone's had their usual support networks available. Very quickly, from DR, are solids now 4 or 6 months? So yeah, certainly the ASCIA guidelines are from 4 months. The earlier we give solids, the lower the risk of atopic complications. That's assuming you have a child that's ready, so a child that's strong enough to kind of be upright, that's taking an interest in solids, but certainly recommending from 4 months is what we would recommend. I don't know if there's any other questions before we hand over to Anne.
Thank you so much, Daniel. That's we can have a few questions at the end if anyone thinks of anything that's they would like to ask. So we'll hand over to Anne on celiac disease and iron deficiency in infants and children.
I'm just trying to screen share here.
Oh, sorry. I'll see if I can. Do I need to get rid of mine?
While you guys are sorting that out,
There you go. I've stopped there.
Okay.
While we're waiting for that to happen, I saw a infant the other day, a toddler the other day, 20-monther, who came in with a sore ear. And when we had a look at him, he looked pretty pale, and his hemoglobin was 3, which required some transfusions. So that's a fairly common presentation we see in the ED. And this child had minimal symptoms that would suggest that he was running around with a hemoglobin of 3.
Thank you, Scott. Yes, we've certainly had Werribee. I've certainly seen quite a number of kids presenting with very low hemoglobin, much more than I've realised or seen previously in the last 12 months. So thank you and welcome everybody for coming out tonight. That's very good of you. I'm talking on celiac disease and iron deficiency in children. It's a good topic to talk about because both conditions are treatable and have such a good outcome when diagnosed correctly and treated appropriately. And full disclosure here, like Dan, I'm not using the cases, but both my children are diagnosed with celiac disease. And the third one, who's vegan, is living in terror, thinking he might be looking down that later on in life. So celiac disease, for those, I know you know all of this, but just to go over it, is a lifelong immune-mediated systemic disease which is precipitated by gluten, and that's found in wheat, barley and rye in genetically susceptible individuals. It's different to other food allergies, which are IgE and IgG mediated, as this is mediated by gliadin reactive T cells. And over the last 50 years, there's been a 4-fold increase in incidence. So it's something that you will be seeing and we need to know more about. And the evidence is, it's thought to be that there's a number up to maybe 80% undiagnosed in the community. It's an interesting disease because although you're born with your predisposition towards it, you can develop at any time and age. And the treatment, as you're aware, is a gluten-free diet for life. So the reason for the gluten-free diet for life is the risk to lymphoma and bowel cancers. And I have seen people who've presented with that, but it's generally not seen in paediatric population. It's seen in more the adult population with celiac. So the classic celiac disease, which I learned about in medical school, is the malabsorption with steatorrhea, weight loss, and vitamin and micronutrient deficiency. So that can include iron, but also zinc, B12, vitamin D. And so it has a very profound effect on the health of the individual. It has characteristic biopsy changes in the small bowel, and we'll have a little look at that. And the resolution of symptoms with a strict gluten-free diet can take weeks, but up to months, and so sometimes even 12 months. So this is a picture of classic celiac disease that with the abdominal distension, the wasted buttocks, and the poor nutritional stores in a child. And anybody can see that that child is very unwell. This is the healthy small intestine on the left here with long villi. And this is the villus atrophy that we'll see in celiac disease in the duodenum when you're scoped. So the infiltration of the epithelium with lymphocytes, crypt hyperplasia, and villus atrophy is very typical. And there's a classification called the Marsh criteria where you can go from 1 to 4 depending on the severity of the changes. The GI symptoms are chronic diarrhea in the young, but you need to also remember that older children can present with constipation. And so if you're only looking for diarrhea, you might miss that. They often have abdominal distension and pain associated. So any child with abdominal pain should be considered to have possible celiac disease. And sometimes they'll complain also of bloating after meals containing pasta or bread. They will often show poor weight gain or weight loss, and Dan has covered that beautifully, and vomiting might be a feature of the typical GI symptoms that you see. The non-GI symptoms are the interesting ones. So these, I think, are where we're seeing our increase in celiac disease presentations, particularly in the pediatric age population. And so they can present with neurodevelopmental symptoms. So that might mean depression, anxiety, just generally feeling very low mood. They may just on testing have liver disease with elevation of transaminases for no other, and if you can't find another reason, think of celiac disease. We've talked about, or Scott's alluded to, iron deficiency, and iron deficiency, particularly when you've treated them appropriately with oral supplements and it hasn't responded, think of iron deficiency. And that's where I actually diagnosed my daughter, because she had iron deficiency not responding. She was an adolescent, she had heavy periods, and I was rechecking her iron level, was being rechecked and suggested checking for celiac disease, and she was positive and went on to have a scope. The other classic form of non-GI symptom that we see is dermatitis herpetiformis, and I'll show you some pictures of this. And this may present to the dermatologist and has a typical biopsy appearance, and that on its own, if diagnosed on biopsy, is a diagnostic of celiac disease, and you don't need to have a bowel biopsy to confirm the diagnosis. Poor dentition, so the teeth can have a very typical appearance with grooves which are symmetrical, as well as brown pigmentation on them. You may have a child who's got unexplained fractures or osteopenia, and this is the secondary hyperparathyroidism they get with their vitamin D deficiency. They may have arthritis or arthralgias, chronic fatigue, common presentation in the adolescent age group. Don't always just assume it's post-viral or a mood-related fatigue. It could be celiac disease that's causing it and affecting their mood with their neurodevelopmental symptoms as well. Recurrent aphthous stomatitis. If you can't find another reason, always helpful to check for celiac disease. And short stature, and among that I use pubertal delay as well. So a kid who hasn't gone into the normal Tanner stage of puberty that you'd be expecting, and it's always very helpful to do when you're doing your baseline bloods, investigating to throw in a celiac serology as well. So this is the rash of dermatitis herpetiformis on a cheek. When you see it, it's usually erythematous, papular vesicular, and it's often symmetrical. Here's another example. It's highly pruritic, and often when they have this rash, they may have no GI symptoms in 90% of cases. The other places that it's said to occur is on the knees, and also on the elbows and on the buttocks as well. So if you see an unusual rash that's vesicular, highly pruritic, think of celiac disease. This is the dental problems that you might see. And so they've got the groove across the teeth and the brown pigmentation as well. So testing for celiac disease. When I started out, we used to test for celiac disease by doing 3 scopes, and there may be people listening today who remember that. So they would be tested when they were on a gluten-free diet. They would have a biopsy and under upper endoscopy, and that in children involves a general anaesthetic, as in adults, or they'll obviously have that under sedation, but in children it's a general anaesthetic. So for the testing, they would have a biopsy done under anaesthetic while on the gluten diet. They would then be taken off, and it would be repeated again 6 to 12 months later. And then they would be re-challenged with gluten and a further biopsy done. So obviously a really big process for families to go through. Celiac disease, however, has moved on, in that we're now able to screen for it quite well with serology. And I want to go through that because the serology has changed over the time, and it is quite confusing. I get confused by it. And so I want to try, my take-home message today is to simplify the understanding of how we should test for it and give you pathways that you know what to do. My take-home message also, though, is that if you are suspicious of celiac disease, and even though the serology may or may not be convincing of it, it is always appropriate to keep that child on a gluten-containing diet and refer to a gastroenterologist so that they can make a decision about a scope, as approximately 2–3% may not have positive serology. So why do we test for celiac disease? Because it's a common disease. The prevalence is thought to be between 1 in 80 to 1 in 300. There is a slight preponderance towards females over males. The other group of children that we screen for in pediatric population is those who have a 1st or 2nd degree relative, and that increases their chance of having celiac disease by about 10%. If you have other examples of autoimmune disease, such as insulin-dependent diabetes or autoimmune thyroiditis, they are routinely screened as part of their diabetes or thyroid management for celiac disease. In the clinic, when I was looking after the diabetics, we used to do it 18 months to 2 years, but I think realistically, as long as you're doing it every 3 to 5 years, that's appropriate. The other children that are more prone to it is JCA. That's slightly less an incidence of about 3 to 5%. But there are conditions as well which are more prone to it that we commonly see through our clinic, including Down syndrome, Williams syndrome, and Turner syndrome. And these children will routinely have every 3 to 5 years, they'll be checked with celiac serology as well as thyroid antibodies. So when you're doing serological testing, it is important that you ensure that the child is on a gluten diet prior. If they're not, because the parent may have taken them off because they believe that they might be sensitive to it, and that's actually quite common, they need to be having something between 1 to 2 slices of bread every day, or the equivalent of that, for about 6 to 12 weeks before you should be testing them. The tests that we all should be ordering is the tissue transglutaminase, IgA. This is a highly sensitive and specific test of over 96%, and it is the most cost-effective test. There is another test, which is the endomysial antibody test, but that is a much more expensive test, and so it is always used second line. When we measure the tissue transglutaminase, we also measure IgA, and that's because if you have Iga deficiency, that may give you a falsely negative test. Now, Iga deficiency is about 1 in 600, and 85% of people who have it are asymptomatic, have no symptoms at all. But when you're measuring IgA, it's low in the first few years of life, and it increases, and you will be able to pick it up generally by the time of the age of 4, but between 2 and 4, it's fairly reliable. If you have a child who's under 2, therefore, where this test might be negative, we generally will order an IgG test. And the one that's often ordered is the deamidated gliadin peptide. And that's useful for this group of children under 2 years of age who have symptoms suggestive of possible celiac disease. In the past, anti-reticulin and anti-gliadin antibodies were the ones that they were recommending, but they're now no longer recommended and have been superseded. And the tissue transglutaminase IgA is the one we should be looking at doing in most of the patients that we see with an IgA level at the time. Hla genotyping. So this is another thing that's become quite popular. The problem with this is that 30 to 50% of the general population will also be positive, but not have celiac disease. So it's a very common finding and is not helpful but in the average child that we're seeing that we're screening. It's not required to diagnose the patient either. And it's an expensive test. The Medicare rebate is close to $120, cost to Medicare is about $120 per test. It is helpful though for screening. And so a negative test means your risk of having celiac disease is very low. And so if you have somebody who's refusing a gluten diet and you just want to be 100% sure, it has value in that setting. So the criteria for diagnosis when you're getting your results back is that you look at the tissue transglutaminase IgA, and if it's above 3 times the upper limit of normal, and this depends on the lab that you're ordering it from, because they all have their own reference ranges, then biopsy is the next step. And what we should be doing is saying to the family, stay on the gluten-free diet, that's very important, and go and referring off to a pediatric gastroenterologist for a biopsy. So the biopsy has to be done under direct vision and can't be a capsular biopsy because they take several biopsies from the duodenal cap, and that can't be done reliably with a capsule. If, however, the tissue transglutaminase is positive, but less than 3 times the upper limit of normal, there is value in adding in that EMA IgA. If that's then positive, again, you would then proceed to a biopsy, keeping the child on the gluten-containing diet. However, if at that stage the EMA is negative, then it is reasonable to observe and repeat at a later time. And usually we do that every maybe 3 to 6 months to make sure that this is something that we are going to pick up celiac disease, which may be evolving over time. What happened last year, there were new guidelines, and these are trying to avoid the need for all children to have a upper endoscopy and scope and a generalist anesthetic associated with that. And these have come out from the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition. And there are North American guidelines as well, which are similarly supportive. And it's suggesting a no biopsy approach, which is safe in children who have a tissue transglutaminase IgA, which is greater than 10 times the upper limit of normal. So a very positive result. Their recommendation is that you then repeat in a second serum sample, so not at the same time, an EMA, and make sure that that is positive. And then they recommend that it is safe to consider demonstrating a clear clinical response to a gluten-free diet with normalizations of the titers of the serological testing in 6 months. If, however, the tissue transglutaminase is less than 10 times the upper limit of normal, they would always recommend referring on for a biopsy. So these guidelines are coming into force, and there are some gastroenterologists who are completely on board, and then there are others who are a little bit more qualified in their approach. I think at this stage, what we would recommend is that every child is referred on to a pediatric gastroenterologist so that they can make the call on this. But the important thing is that HLA testing and presence of symptoms are not obligatory criteria. So I've got 2 cases here, and these are 2 cases that I've had in the last 3 months. And having had 2 children myself, I've diagnosed with celiac disease. I've gone looking for this, and I find this celiac disease very frequently, maybe 6-7 times a year, and they're classically not the child with failure to thrive with diarrhea. So this is Charlie, and he's a 5-year-old boy who was referred by his GP for concern of his short stature in comparison to his peers. He had constipation, mouth ulcers, and fatigue. When he was examined, he was pale, and just in the interest of time, his weight was at the 90th, his height was at the 25th percentile. He had a ferritin measured, which was low at 14. He had been on iron supplements, and this shows a deamidated gliadin IgG 108, a transglutaminase IgA 34, serum IgA normal, and he actually had an EMA, and that was negative. And I was going to make this interactive, but in the interest of time, what I would say is that this is not a diagnosis confirmatory of celiac disease. It's one where we would, the IgG is unreliable. The tissue transglutaminase IgA is elevated, but not at a level that needs referral. And so the recommendation would be that we would repeat this and follow this child closely just to see what his serology does with time. I have another child here, Jack. This is another one that I saw fairly recently. He came from his GP with a history of lethargy, iron deficiency, and mild lymphopenia and neutropenia on his blood count. He was on treatment with oral iron. Neither Jack nor Charlie had any bowel symptoms that parents were aware of or they were complaining of. Jack was a child. His weight and height were following at the 10th percentile, but he had a low ferritin. I was checking him again to see whether he'd responded to his oral iron. His ferritin remained low, and as you can see here, he's got very elevated tissue transglutaminases IgA. He meets the criteria for above 10 times the upper limit of normal. He went on to have a second blood test and was EMA positive. And so he is in a group that would be considered as possibly not requiring a biopsy. But what I've done is keep him on a gluten-containing diet, and I referred him on to the pediatric gastroenterologist. I can discuss it with him so that can make that call. The problem we have is often, though, that, as you probably know, is that it takes such a long time to get into them. And if the parents can think that they can resolve all their symptoms by taking them off the diet, they are keen to get it done quickly. So that was my talk on celiac disease. Scott has already covered very well iron deficiency in children, so I'll run over this quickly for you. It is the most common nutritional deficiency in children. The 45% of children worldwide are felt to be iron deficient, as Scott was alluding to. And in developed countries, but within socially, economically challenged areas, up 25 to 40% are felt to be iron deficient. So really important to recognise, because the potential for poor neurocognitive outcome is really high, and they often, as Dan was alluding to, present with developmental delay. But it also is associated with other conditions. They can actually get venous sinus thrombosis as part of their iron deficiency. That's rare, but is described. Breath holding spells are problems which can be improved with iron supplementation. It's associated with benign intracranial hypertension and cranial nerve palsies. You have an increased risk of febrile convulsions when you're iron deficient, and the sleep physicians love it for poor sleep in children, as it's associated with restless leg syndrome, and they always recommend a supplement to children who they're seeing who are waking overnight, and it's a simple thing that you can do. So it's predominantly a nutritional disorder, and that means that either it's the dietary, that's no red meat, or excess cow's milk, as Scott was talking about. It's rarely due to malabsorption, inflammatory disorders in children, but it can be in celiac disease, IBD, such as Crohn's disease, and non-IgE mediated cow's milk protein intolerance are associated with it. In infants, the important things to find out about is was the mother maternally iron deficient during the pregnancy, and did she take her supplements? Well, the risk factors was the baby premature. Most of the iron gets deposited in the last trimester. Was there a twin delivery? Are they exclusively breastfeeding after 6 months? Was there a late introduction of solids? And as you mentioned, Scott, excess cow's milk consumption. So children and adolescents, slightly different. The vegetarian or vegan diet is more likely to be the cause. They may be presenting with Crohn's disease or IBD. There may be causes of chronic blood loss, and heavy menstrual bleeding is something that needs to be considered in the right population. And extreme athletes. And extreme athletes, they have increased iron needs, and they also sweat out iron. So some of these children, who are endurance athletes, are at risk of iron deficiency. So the symptoms can be poor school performance, they can be irritable, unhappy children with fatigue, and pica. And there is a pica, which is the ingestion of non-nutritive substances, which we can see in sort of autistic or intellectually disabled children, but otherwise in children with iron deficiency. And there is the pagophagia, which is specific to a condition specific to iron deficiency, where children eat ice, which I hadn't actually heard about until I was reading for this talk. So what do we test for it? Serum ferritin alone is all that's needed. We don't need everything else. Ferritin will give us the answer, but we need to remember, when are we taking it? Because it's an acute phase reactant. So if they're unwell, coming into hospital with an infection or a fever, it's going to be raised, and we won't be able to interpret it. The full blood count is obviously needed to diagnose the iron deficiency anemia, which we do see quite frequently at Werribee, and the lowest one we had was 2.7 last year, and they often have a microcytic and hypochromic picture on the blood count. But we also see that in children in our population with alpha beta thalassemia, but they will often have a normal hemoglobin. You treat them for their iron deficiency, and then you repeat it and then go on. And if they're still microcytic and hypochromic, you'll do a hemoglobin electrophoresis. So treatment is dietary. So involving the dietitian, really important. As with celiac disease, the dietitian is crucial in the treatment of the condition, and the same with iron deficiency. And so referring them off is really important, but also looking at iron supplementation. The dietitian is going to increase the iron-rich foods, and we're going to reduce cow's milk consumption. So cow's milk should not be given under 12 months to children. They should be on formula, and formula will be iron enriched. And over 12 months, the maximum intake that we should be ensuring these children are having is 400 to 500 mils a day. Iron supplementation, even for the really low hemoglobin we had last year of 2.7 at Werribee, which was iron deficiency, that RCH were happy for us to only treat with oral mixture. So the RCH guidelines have a really helpful guideline on this, where you can look up the weight of the child and the dose that's needed. So we either use a ferrous oral mixture, a ferrous sulfate delayed release capsule, or a spanziol and ferrous sulfate tablet. And the supplementation is 3 to 6 milligrams per kilogram per day in 2 or 3 divided doses. And if we give with vitamin C, it increases absorption. And we don't give it with milk because that will impair the gut's absorption, because casein will prevent it from being absorbed from the gut. Sorry, I'm just having trouble with my slide. So this is the Children's Hospital guideline. Just have to remember that it will stain teeth. So you really need to tell parents about that and brushing their teeth afterwards. The spaniels are good because you can open them up and sprinkle them on food, particularly for autistic kids who generally are very fussy with their diet as well, and they can hide it in food. And then the tablets, obviously, for older children. So this is taken directly from the Children's Hospital guideline, which is just helpful to direct parents to and to look at. And that was for mild and moderate, and this is for severe. So responders, they'll show an increase in 2 to 4 weeks in hemoglobin concentration. So for those ones who are affected with a low hemoglobin, you need to repeat that and make sure it's responding. So non-responders, you need to look into that and make sure there's appropriate dosing with iron and that the family are adhering to treatment. If they are doing all that, you need to think of other GI causes, and we talked about celiac disease and Crohn's disease. And then just to mention that there are some rare genetic disorders, of which this is a mutation in this gene here, where they don't absorb iron from the gut. And sometimes you meet families and they say, everyone's iron deficient in my family. Parenteral iron supplementation is available. There is a risk, however, of anaphylaxis and permanent staining of the skin with extravasation. So it should only be used very sparingly in children. And these are the conditions that we use it in. And we do it at Werribee over the age of 14 in day surgery. They can be referred in. But my take-home message really here is that oral supplementation of iron rather than IV iron should be the way to go because of anaphylaxis and permanent staining. And I think I've just finished.
Thank you so much, Anne. So that was terrific. There's not too many questions that I can see on the chat room, so you've obviously answered most of the questions. Mike, I've got a question regarding the fact that mild iron deficiency anemia is probably with a hemoglobin over 80. Would you expect that? Would you be happy for GP to be managing that without needing for that to be referred if the diagnosis is clear on the full blood count and the serum ferritin is appropriate? I don't think there's a need for them to be referred on if they respond.
No, I think if they're responding and you're very comfortable with them, then no, absolutely. But I would make the point that if anybody is uncomfortable with any paediatric patient, as Dan was saying at Werribee, we're more than happy to be contacted and guided and advise or review the patient. But if you're obviously, if you were seeing them and you were absolutely comfortable with managing them, I absolutely would be happy with that.
Another comment on the celiac is one of the things that we put in the pathway is if you do have a child who's positive for serology, and the parents are quite concerned about keeping them on gluten before they have the endoscopy. We are advising that you ring the gastroenterology registrar, put the referral in and let them know that they're waiting, and they will actually expedite the endoscopy. That's the information that I was told, that if you do all the grunt work and you do find a positive celiac, keep them on the 2 slices of bread a day and tell them that you'll really try and get the endoscopy done as fast as possible. And I think they're quite good at doing that. That's
great to hear that. I have to say the other side of the city is a bit slower. So it's great to hear that we've got that service, because if I had a child, they want to get done straight away.
Mm. Well, thank you so much. We sort of got to the end of the time. So the health pathways have covered, luckily you didn't say it'll put anything that I think, oh my gosh, that's not in there. So, so the three pathways that will give you some summaries about all this is the toddler and infant nutrition concerns that will cover the iron deficiency. We have a celiac pathway in children, and also we have a slow weight gain, or sorry, slow growth in children pathway, which sort of mirrors the clinical practice guidelines. And if you're not into the health pathways, the CPGs also have some terrific guidelines, particularly on the iron supplements and what to give for kids. So thank you everyone for joining in, and don't hesitate on